Bom, boa noite a todos. Nós vamos dar início ao nosso Grand Round, em especial essa noite associado com o Chicago, né? Então, essa primeira abertura eu estou fazendo e, a seguir, vou chamar a doutora Norma para abrir quando entrar junto com o Chicago. Vamos começar, então, Juan, por favor?
Alô, boa noite.
Posso só dar um anúncio, se tiver alguém assistindo? So, welcome UIC and Illinois Eye and Ear Infirmary. We are having their special participation in tonight's grand round. And our first cases will be presented by residents from Unifesp. And any comments are really welcomed. Thank you very much. Juan, you can begin.
Ok. Boa noite a todos. Eu sou Juan, sou residente do segundo ano aqui do serviço. Minha preceptora é a doutora Camila Campello e o chefe do setor é o doutor Carlos Eduardo Souza. Eu vou estar apresentando o caso de uveites, do setor de uveites. Aqui trazemos uma paciente de 30 anos, natural e procedente de São Paulo, com uma queixa de baixa de visão progressiva do olho direito há 3 meses. Essa baixa de visão era, como eu já falei, progressiva, com dor, e também foi avaliada inicialmente em outro serviço, onde foi inicialmente levantada a hipótese de necrose aguda de retina, e foi iniciado a ciclovir 4 gramas dia, prednisona 40 miligramas dia e prediforte tópico de 8 em 8 horas. Associado, e aí foi encaminhado ao nosso serviço para poder continuar a investigação. A partir daí, ela negava quaisquer comorbidades, traumas ou medicações contínuas de antecedentes oftalmológicos. Ela referia 2 episódios prévios de uveíte, sendo o primeiro 2 anos atrás, e o segundo episódio sendo 3 meses antes dessa apresentação. Ambos os episódios foram tratados com corticoide tópico e com boa resposta. Na chegada ao nosso serviço, aproximadamente há 1 ano atrás, a paciente apresentava no primeiro exame uma acuidade visual com melhor correção do olho direito de conta-dedos a meio metro, do olho esquerdo de 20/20, ao exame da biomicroscopia do olho direito, uma conjuntiva clara, uma córnea transparente, uma câmara anterior ampla com reação de câmara de uma cruz, com flare e sinéquias posteriores, sendo fástica. Do olho esquerdo, paciente com exame normal, sem reação de câmara, a pressão intraocular do olho direito de 12 milímetros de mercúrio e do olho esquerdo de 14, e na fundoscopia do olho direito, a paciente apresentava um disco óptico hiperemiado, com bitrate de 3 cruzes, sendo difícil avaliar mais detalhes da fundoscopia. No olho esquerdo, a paciente apresentava um disco óptico róseo, bem delimitado, escavação de 0,3, com vasos e máculas sem alterações, com snowballs na retina, no quadrante inferior, com a retina colada na periferia e 360. A partir daí, podemos pensar em algumas hipóteses.
Túlio.
Boa noite, tudo bem? Bom, temos então aqui uma paciente de 30 anos, né, com uma baixa de visão no olho direito, iniciou há mais ou menos 3 meses, progressivo. No exame a gente vê, então, uma vitreite de 3 cruzes no olho direito, sem lesões a priori na retina visíveis, precisaríamos talvez primeiro em uma uveíte intermediária, mas também a gente tem que notar também que no outro olho também tinha snowballs, que poderia significar uma sequela de uveíte. De hipóteses diagnósticas, podemos pensar inicialmente infecciosa, sífilis, tuberculose, como causas inflamatórias sarcoidose, volticoianagem rarada, e também poderemos pensar em causas neoplásicas, como linfoma ou talvez uma síndrome mascarada.
Exato, Túlio, muito bem. Eu queria ressaltar que nesse quadro, onde a paciente apresentava essa vitreite sem lesões no fundo de olho, como o Túlio já falou a priori, associado também com esse snowball do olho esquerdo, pensamos em uma uveíte intermediária bilateral, mas de forma assimétrica. Então, a partir daí, poderíamos pensar nas etiologias que o Túlio já comentou. Aqui, para a conduta, um residente.
Continua, Túlio.
Perdão. Bom, para a conduta, a gente tem que pensar inicialmente nas infecciosas, fazer um screening com sorologias. Para tuberculose, sarcoidose, também seria interessante pedir exames de imagem, talvez uma TC de tórax, que poderia mostrar principalmente os detalhes da sarcoidose. Poderíamos, talvez, até cogitar um líquor no vulgo de coronagem rarada, pensando no padrão típico. Linfoma seria bom também pedir hemograma, exames gerais.
Certo. Então, a partir daí, como a história do paciente, ela chegou usando a ciclovir, pensamos em suspender a medicação, fazer as sorologias e os exames laboratoriais gerais, pedir um ultrassom ocular para avaliar o olho direito, se tem uma lesão posterior, descartar uma síndrome de difusão uveal, uma uveite posterior, e também solicitar tomografias de crânio e tórax. A partir daí, os exames mostraram as sorologias para sífilis, tanto o VDRL como o teste treponêmico negativos, a toxoplasmose, tanto IgG positivo e IgM negativo, o teste de HIV negativo, HTLV negativo, o teste para tuberculose, que é o PPD, de 0 milímetros, aí o hemograma normal e um FAM pontilhado fino de 1 para 160. A partir daí, o ultrassom demonstra aqui um processo inflamatório vítreo importante, um descolamento de retina das 2 às 5 horas localizado em Equador, tem um espessamento, incluindo a área macular, e uma sobrelevação em área papilar associado a fluido perineural. Um fluido subtenoniano em meridianos inferior e temporal superior também é observado. Então, tudo isso fazendo parte desse processo inflamatório, associado a esses exames complementares, demonstrando tomografias de crânio, de abdômen, de tórax, no caso aqui embaixo, como vemos na parte de crânio e abdômen normal, e no tórax vemos uma calcificação de um linfonodo residual no hilo pulmonar, e vemos linfonodos mediastinais proeminentes em número nas cadeias perivascular, prevascular, paraórtica, medindo 0,1 centímetro no seu menor diâmetro, com calcificação de permeio. A partir daí, a evolução da paciente, ela foi iniciada com corticoterapia oral regressiva, apresentando uma excelente resposta a essa terapêutica, recuperando a acuidade visual do olho direito para 20/60, lembrando que era conta-dedos na primeira apresentação, e foi feita a regressão do corticoide mensal, até que a paciente, ao chegar aos 5 miligramas diária, a paciente apresentou piora da acuidade visual. A partir daí, foi optado por realizar uma injeção subtenoniana de triancinolona e um novo ciclo de corticoide oral regressivo. A paciente respondeu muito bem a essa opção terapêutica. Só que ao chegar em abril de 2021, a paciente veio queixando do olho esquerdo com uma mancha nova que não tinha antes do olho esquerdo. A partir daí, o exame no olho esquerdo, tínhamos no olho direito uma acuidade visual de 20/40, do olho esquerdo também de 20/40. No olho direito não tinha mais reação de câmara, tinha ainda um flare, as sinéquias que já tinha antes, e do olho esquerdo vemos alteração de reação de câmara de uma cruz com celularidade vítrea de 2 cruzes nesse olho esquerdo. Lembrando que ele não tinha essas alterações antes. A partir daí, a pressão intraocular normal e a fundoscopia que eu vou mostrar agora, o olho direito, vemos um disco óptico com edema residual, um pouco permeado, com um descolamento de vítreo posterior, um descolamento de vítreo aqui parcial, já residual também, e sem outras alterações na mácula ou vasos e a retina colada. No olho esquerdo, queria denotar aqui uma lesão a partir do disco óptico mal delimitado e permeado, um aumento discreto de tortuosidade vascular e uma lesão com bordas mal delimitadas subretiniana em polo posterior, A partir daí, optamos por fazer uma tomografia de coerência óptica do olho esquerdo, dos dois olhos, mostrando aqui do olho direito interface de vítrea sem alterações, vitro-retiniano também, com as camadas preservadas, sem líquido subretiniano no olho direito, e no olho esquerdo vemos aqui uma alteração, uma elevação aqui da região subretiniana com um líquido subretiniano associado, podendo corresponder a um granuloma de coroide. A partir daqui, vemos a lesão em maior detalhe, uma elevação aqui, correspondendo a esse granuloma de coroide. Aí optamos por realizar um novo ciclo de corticoide oral, que a paciente respondeu muito bem. Depois de ter terminado esse ciclo, a paciente, em junho de 2021, um exame atual da paciente demonstrando o olho direito com a descrição mantida, e do olho esquerdo vemos que essa lesão subretiniana elevada que tínhamos visto no slide anterior, ela não se encontra mais aqui, ela foi resolvida a partir do novo ciclo de corticoide. Aqui vemos também o OCT demonstrando essa resolução da elevação da coroide aqui, com o líquido subretiniano, que já não temos mais nessa imagem. Então, juntando todas as manifestações até agora, temos, primeiramente, esse episódio de pão-veite no olho esquerdo, com esse granuloma de coroide. Temos a história de ter presenciado uma veite intermediária, bilateral assimétrica. Temos essa documentação da resposta excelente ao corticoide, tanto tópico como oral. E a tomografia de tórax mostrando o linfonodo no hilo pulmonar e o teste de tuberculose anérgico. Pensando nos nossos diagnósticos diferenciais, a sarcoidose foi nossa principal hipótese, e eu queria trazer aqui um breve resumo das manifestações oculares da sarcoidose e dos critérios para considerar o diagnóstico. A partir daí, temos os critérios de sintomas oculares, temos os critérios laboratoriais e temos essa classificação em 4 subtipos de probabilidade diagnóstica. Então, nos tipos de sintomas e sinais oculares, temos os precipitados queráticos granulomatosos ou nódulos de íris, temos nódulos na malha trabecular, com os sinéquias anteriores periféricas em forma de tenda, a vitreite com snowballs infiltrados vítreos em colar de pérolas, lesões corioretinianas periféricas ativas ou atróficas, periflebite nodular ou segmentar, macroneurisma retiniano, e granuloma do disco ou nódulo coroideu solitário. E também outro critério seria a bilateralidade. A partir daí, as investigações laboratoriais seriam o teste tuberculínico negativo, elevação da enzima conversora de angiotensina ou da lisozima, radiografia de tórax com linfadonopatia hilar bilateral, alteração das enzimas hepáticas ou tomografia de tórax em pacientes com raio-x com radiografia de tórax negativo. Então, juntando tudo isso, nossa paciente apresenta esses critérios, tanto clínicos como laboratoriais.
String of pearls, colar de pérolas.
Isso, colar de pérolas.
Eu falei, falou.
E a partir daqui, vemos que, seguindo o International Workshop on Ocular Sarcoidosis, que seria o guideline para o diagnóstico de sarcoidose ocular, vemos que o nosso paciente apresenta um diagnóstico de sarcoidose provável, sendo que tem 3 sinais clínicos e 2 sinais laboratoriais positivos, sendo que a biópsia não foi realizada. E aqui, então, juntando todos esses achados, a sarcoidose é provável diagnóstico, tendo todos esses pontos que eu já mencionei, a excluir outras causas, a resposta excelente ao corticoide, as alterações na tomografia de tórax e os sinais oculares já falados. É isso, obrigado.
Muito bom. Camila, você quer comentar, por favor?
Obrigada, doutora Nilma. Doutora Nilva, Juan, primeiro eu queria parabenizar você pela apresentação, acho que ficou excelente. E queria agradecer ao Cadu o convite de estar aqui orientando hoje o Grand Round. E eu queria, sim, pontuar algumas coisas que eu acho que são interessantes a gente falar desse caso. Eu acho que a primeira mensagem que a gente precisa levar dele que é a coisa que o Dr. Rubens mais fala para a gente no ambulatório, é que o VIIT não é uma foto, em si um filme. E a primeira suspeita que a gente teve para desconfiar desse diagnóstico inicial dela foi justamente essa evolução do caso. Então, quando a gente pensa numa hérnia, a hérnia é uma doença muito agressiva, é uma doença que a gente precisa tratar o quanto antes, e o tratamento é feito com a ciclovia endovenoso ou valaciclovia em altas doses. Esse quadro mais arrastado, mais progressivo, deixava a gente mais em dúvida quanto a esse diagnóstico inicial. Outras coisas que eu acho que são importantes a gente levar de mensagem desse caso é que o diagnóstico da sarcoidose, ele não é um diagnóstico tão simples, apesar de 25 a 60% dos pacientes que têm a sarcoidose sistêmica desenvolverem um quadro ocular, 30% dos pacientes podem apresentar somente as manifestações oculares, sem ter um quadro sistêmico associado. E aí isso torna o nosso diagnóstico ainda mais difícil, tá? E a sarcoidose também, ela é uma doença que ela pode ser manifestada de diversas formas. Aqui a gente teve uma apresentação de uveíte intermediária e de uma panveíte, mas ela pode ser somente uma uveíte anterior, ou ela pode estar associada somente ao granuloma de coroide, e aí é justamente o achado de todos esses sintomas, a exclusão de outras causas, foi que fez a gente fazer esse diagnóstico. Eu acho que era isso. Obrigada.
Eu que agradeço. Alguém mais quer fazer algum comentário antes da gente passar para o próximo caso?
Any comments? Juan?
Cadu não está na sala?
Sorry?
Cadu não está na sala?
Cadu?
Não,
Não,
o Cadu,
ele não
o Cadu,
não.
ele
É
não tá.
Heloísa.
É
A doutora
Heloísa.
Elo que está hoje aqui, doutor Ivan.
Então, Heloísa, por favor.
É aniversário do
Oi.
Cadu. A grande dificuldade desse caso é que é um paciente jovem e é uma doença crônica, então provavelmente ele vai reativar, já reativou com uma dose baixa de corticoide, então a gente tem que pensar em imunossupressão para que ele não tenha perda de visão em longo prazo. A sarcoidose é um diagnóstico muito difícil de ser feito, é raro que a gente consiga uma biópsia positiva, então sempre que esse paciente voltar, a gente tem que reavaliar o diagnóstico e procurar as causas. Algumas vezes, até com PPD negativo, a gente tem paciente com tuberculose que desenvolve uma resposta semelhante à sarcoidose e o diagnóstico é mais difícil. Então, parabéns, Camila, parabéns, Juan, pelo caso, e estou de volta aí, só cobrindo o Cadu hoje. Saudades a todos.
Obrigada.
Maurício, você quer falar algo antes de eu passar?
Não, fica à vontade, Nilva. Obrigado, querida.
Imagina.
Só
Então,
boa noite a todos.
Então, acho que a gente podia mudar, Vitória, para o seu caso.
Ok, já vou compartilhar minha tela. Ok, dá para ver a minha tela em tela cheia?
Sim.
Perfeito. Então, eu vou começar. So, good evening. My name is Victoria. I'm a third-year resident, and today I'm presenting a surgical optics case report. My preceptor is Dr. Wallace Chamon. The heads of division are Dr. Liang Jung and Rafael Kobayashi. So, my case is about a 13-year-old male patient, a student that was born and raised in São Paulo. He was referred to our service for keratoconus evaluation. His past medical, family, and ophthalmology history were all unremarkable. Just emphasizing that this is a very young patient. So, on his dye exam, he had an uncorrected visual acuity of counting fingers in both eyes, a refraction of plano with -8 at 30 on the right eye, and +1.5 with -7 at 135 on the left eye. His spectacle corrected visual acuity on the right eye was 2200. Therefore, this is the eye that we decided to treat first. And a spectacle corrected visual acuity on the left eye of 2025. I'll show you the images of the anterior biomicroscopy. His intraocular pressure on the right eye was 14 and 12 on the left eye. And his Fundus exam was unremarkable. He had a pink optic disc with sharp margins, a cup to disc ratio of 0.3, normal vessels and macula, and an attached retina in both eyes. So this is the anterior biomicroscopy of the right eye.
Guilherme, talk to me.
Good evening. So anterior biomicroscopy of the right eye. We can partially evaluate the eyelids and eyelashes. It seems normal. Clear conjunctiva. This percentral corneal opacity, trophic iris, and seems phakic.
Okay, I'll show you this temporal inferior area with more details later. And in this image, we can also see this conical reflection here on the nasal cornea that is known as Visite sign.
Yes.
So here we have the slit lamp exam of the right eye. We can see the temporal inferior area with more details. So here we have this important stromal thinning with a corresponding epithelium thickening. And here we have the anterior biomicroscopy of the left eye.
So the left side, normal eyelids and eyelashes, clear conjunctiva, clear cornea, trophic iris, and phakic.
Perfect. So a normal anterior biomicroscopy. So for the diagnostic hypothesis?
So it is a 13-year-old male patient who came to evaluate the Fundus. He presents in the right eye a simple myopic astigmatism, in the left eye a mixed astigmatism.
Okay.
Also in the right eye we can see this area of thinning in the cornea. Those findings are something that we can find in a keratoconus diagnosis, so we can confirm this diagnosis. It's possible diagnosis for the patient. And also the patient presents a visual acuity in the right eye, even with correction of 20 to 100. So in the right eye, he presents a low visual acuity, a low vision.
Yes. So he had a previous diagnosis of keratoconus, a simple myopic astigmatism of the right eye, mixed astigmatism of the left eye, and low vision. The spectacle corrected vision was 2200 on the right eye. And the next step for this patient.
Guilherme Avir.
Good evening. So as for the management, I would like to better evaluate the corneal topography. And for that, we could order Scheimpflug imaging and any other type of topograph analysis if the Scheimpflug is not available. And we could also ask for an anterior segmental CT to also add in the evaluation of the topography. That's it.
Perfect. So we asked for Scheimpflug images and anterior segmental CT. So now I'm going to show you the Scheimpflug images of both eyes, where we can see a Kmax of 77.3 diopters on the right eye and a Kmax of 57.6 diopters on the left eye. So we have a more advanced keratoconus on the right eye, which will be the focus of our further discussion and management. Also note that the thinnest point in the cornea here on the right eye is 347 microns. So this is an anterior segment OCT image where we can see this stromal thinning. And in blue, we have this epithelium thickening. Also on that temporal inferior area, we can see in the pachymetry map that we have a minimum pachymetry of 303 microns and a maximum epithelium of 159 microns. So we can see that the OCT image repeats what we saw on the slit lamp exam, and epithelium hypertrophy and a thin area of corneal stroma. So according to our previous slide, the total cornea thickness is 303 microns. The residual stromal thickness is 144 microns. And also we have a total corneal length of expected damage area in a cross-linking of 1.5 millimeters. This is a hypothetical cornea where we have a diameter of 10 millimeters, an area of 78.5 square millimeters, a cell density of 4,000 cells per square millimeter, which would give us a total cell count of 314,000 cells. So this little circle here represents that thin area that has a 1.5 diameter, an area of 1.77 square millimeters, and a total cell count of only 7,000 cells. So if we treat this patient and we lose all the cells in this thin area, this would only count for a 2.23% loss. So the expected cell count after treatment would still be 3,910 cells per square millimeter. So for the management, at this time, we decided to perform an AP of hypoosmolar cross-linking on the right eye, following Dresden protocol with 3 milliwatts per square centimeter for 30 minutes, leaving epithelium only over the thin area. So now I'm going to show you the 5-month follow-up exams. So here we have the Scheimpflug images after 5 months of treatment, pre-cross-linking, and the differential map. So here we can see this flattening, especially in the 150 meridian, with a compensating steepening superiorly, which denotes a successful treatment. So here we have the some post cross-linking anterior segment OCT images, where we can see here the demarcation line after cross-linking. I'll show you with more details later. And also the post-operative image of the thin temporal inferior area. So here we have the demarcation line in yellow. And here in more details, the demarcation line at 108 microns. So for take-home messages, attention to image exams in irregular cornea. We would like to stress the importance of epithelial thickness, to consider the possible area of damage before contraindicating cross-linking, and to always remember that young patients with thin corneas and progressive keratoconus, they have limited chances of avoiding keratoplasty. At last, we brought this article that was published in April this year about the effect of corneal cross-linking versus the standard care on keratoconus progression in young patients. So we saw that in this study that they had keratoconus progression in only 7% in the cross-linking group and 43% in the control group after an 18 months follow-up. So as a conclusion, we believe that cross-linking must be considered in young patients, even if they present localized thin corneas. Thank you.
Great. Wallace, please.
Can I make comments, Wallace?
I really don't think I can add anything else. I mean, she was perfect and very good, very well presented. Congratulations, Victoria. I'd like to hear from our colleagues what are their considerations about it. We know this is a polemic. I mean, there's discussion about our treatment. We weighed the risks and the benefits that this specific patient could face. And that was a medical decision. This is not part of a protocol. It was a medical decision. We know there was a risk associated with this cross-linking. Using Dresden protocol, we did not save any energy to try to get success in stabilizing the cornea. But I'd like to know comments.
Also, Kobayashi, né?
Hi. Just to congratulate Victoria for the presentation, and never forget that we have also to tell the patient to stop rubbing the eyes to stop the progression of the keratoconus. And when we did this treatment, we still didn't have the publication of Emilio and Hafezi of the sub 400 cross-linking protocol, which makes the Dresden protocol with less time for the laser. Okay.
I'd like to make a comment on that. For the ones that have not seen this paper of thin corneas treatment. And the question is, if we would apply this approach to this patient, the amount of energy that would be delivered on this specific patient would be less than 10% of the needed or the Dresden protocol. Again, we know that cross-linking in young patients are much less effective. Again, 43% of non-progression in 18 months is not an ideal result, but we know that keratoconus progress much more in young patients. So if we would treat this patient with 10% of the energy that we did, it would probably not work. So that's exactly what we waited. We decided to run the risk of damaging some endothelium cells, but to make sure that this patient would at least postpone the need for keratoplasty. Again, if we have any, I see there are residents from UIC here. I can remember my old times over there and push them and ask them to comment on that. Dr. De La Cruz would love to see what they would say about it. Do you want to make any comment? Please, feel free. Okay. No comments. Who else? Anyone from cornea? Is Luciani over there? Lauro. There's so many people that I can't run the names, you know, the 330 people here.
Is Liang going to make comments on us? Or?
He should. He's the boss.
No, I have Rafael Kobayashi as my refractive guy, so I share everything that he's talking about. But yeah, you may. Where is Jose de la Cruz? Is he in the room?
No. Mauro Campos is asking to speak. Mauro, please.
Well, it's just a few questions, very, very easy. Why the demarcation line is so superficial? Normally, you find like a 300 something depth in this kind of cornea, and this is 110. Considering that the epithelium intact zone is only over the damaged area. This is the first question. Second question is, how often do you see like a keratoconus cornea that looks like anterior disease, such as this? When you see this patient at the slit lamp and also at the OCT, it looks like the disease started from the very anterior part. The anterior stroma, let's say, got thinner, and then the epithelium comes and covers it. Because normally you see it's opposite. The epithelium is thinner than the other areas, and the disease looks like it's coming from the posterior part to the anterior part. In this particular case, everything is opposite. You see very thickened epithelium, and the anterior segment of the stroma looks thinner. So I would treat the patient the same. The just thing is the clinical picture in this keratoconus doesn't look like familiar for me. That's the 2 points I would like to address.
Mauro, those are great questions. The first question is the easiest one to answer. We don't know. It is a shallow demarcation line. As you know, it happens. Demarcation lines vary a lot. And for some reason, this patient had a very shallow 108 demarcation line. The second question, though, I think it's very clear. Some of us, we confuse thin corneas to steep corneas. Normally, in a keratoconus, you have the thinner part of the cornea at the steepest of it. Therefore, the epithelium will be thin, not because the cornea is thin, but because the cornea is steep. So this is a situation where the thin stroma is not localized at the steep or the apex of the cornea. Therefore, the epithelium will fill it and will thicken. So what causes the epithelium to thin on the apex of the cornea, it's not because the stroma is thin, but because this is the apex of the cornea. So therefore, there's more pressure over the epithelium cells and it thins. When you have it not at the apex, you have less pressure on the epithelial cells, and therefore it thickens. So I think this is exactly what's expected. I have seen quite a few patients with those eccentric thinning of the stroma. It is important to know that if you look at the maps and not look at this patient at a slit lamp, you don't need the OCT. The OCT here was just, figurative. You didn't know that. You didn't need that. But if you look at the slit lamp, you see that the exams that are showing you epithelium thickness, corneal thickness, they're all wrong. So that's why the take-home message is, don't trust exams. If you look only at the exams, you're going to find that it never happens. So look at the slit lamp. That's what we did here.
Wallace, why do you think that the thinnest part did not get ectatic?
Oh, that's a second question. That's a much harder one to understand.
Because it's a 150 cornea, very thin, and no ectasia over it.
I agree with you. But if you look, but if you look at a marginal pallus degeneration, the thinnest part is not the one who's the steepest. So steepening is not exactly at the thinnest part. And the other thing that we have always to remember is the thickness of the cornea is part of corneal resistance, but the resistance of the cornea itself plays a role. So maybe the thinnest part there is not the least resistant one. So there are two variables, the thickness of it and the resistance or the elasticity of it. So I think, again, those are questions that we can't answer, you know that. We can't measure corneal elasticity in living eyes so far, especially with topographic tracing. Good questions, like it.
Yeah, great. Thank you.
It's all yours, Norminha.
Okay, let's introduce our colleagues from Illinois Iih Infirmary. So I know the resident will be Catherine Jotikov. Am I right in the how to
yes, that's
your
correct.
name? Hi.
Hi.
And your preceptor in this case will be Dr. McIntosh.
That's correct. Good evening, everyone. Thank you for inviting us.
Hello, good night. So, microphone is yours. You can present. What we usually do is we call our residents to give some ideas about the case in the middle, okay? But you say what's the best.
Okay, that sounds good. So hi everyone, my name is Catherine Joltikov. I'm a PGY3 resident at UIC, and I'm going to be presenting two neuro-ophthalmology cases today with Dr. McIntosh. So our first case is a 14-year-old Caucasian female who presented with headaches and binocular double vision. Now, the differential diagnosis for headaches and diplopia is quite broad. Most importantly, we want to start off by ruling out life-threatening conditions that are going to need urgent management. So we want to make sure that there is no mass lesion or aneurysm hemorrhage. And then we want to consider things like infectious processes. So is this an infectious meningitis or intracranial abscess, or perhaps a sinusitis that has led to an orbital cellulitis? Or perhaps there's some vascular issue like a venous sinus thrombosis or a microvascular nerve palsy, which of course would be unlikely in a 14-year-old. You also have to consider inflammatory causes like inflammatory granulomatous meningitis, Tolosa-Hunt syndrome, and idiopathic causes like idiopathic intracranial hypertension, which can be truly idiopathic or secondary to an exposure, as well as ophthalmoplegic migraine, which can present with headache and diplopia. So let me tell you more about our patient. She initially presented at age 14 in 2016 with right eyebrow and temple pressure-like pain that was 7 out of 10 in intensity. She also had horizontal binocular diplopia in right more than left gaze, associated with blurry vision. Her symptoms did not resolve after outpatient treatment for migraine and sinusitis. Her ocular history was unremarkable. Medical history was significant for obesity and acne. And in terms of medications, she had been on doxycycline for 1 month prior to presentation. Family history and social history were unremarkable. Here's her exam. So her vision was 20/25 minus OU. Color was full, 11 out of 11 in both eyes. She did have a relative afferent pupillary defect in the right eye, and her motility was limited in the right eye, minus 1.5 in abduction. With Maddox rod testing, she had an exotropia in primary and left gaze and esotropia to right gaze. Confrontational visual fields were difficult in the inferior fields for the right eye, but were full for the left eye. And her pressures were healthy and her Hertel measurements were within normal limits. Here's her Goldman visual field that was on presentation. You can see she has enlargement of the blind spots, as well as inferior and nasal constriction in the right eye with a superior temporal island remaining. And here is her fundus exam. You can see that in her right eye, she has 360 degrees of disc edema with partial vessel obscuration and hemorrhage inferiorly. We'll probably call this Friesen grade 3 disc edema. And then in the left eye, she also has 360 degrees of disc edema, total obscuration of some of the vessels, and heme throughout the optic disc margin. I would probably call this grade 3 to 4 disc edema. And at this point, we think about what other tests do we want to obtain. And we went ahead and we got a CT head, which was normal. And then we got an MRI and MRV brain in orbit with and without contrast. And we can see here an example of the axial T2 image as well as the MRV. So the report read that there was flattening of the posterior globes, tortuosity of the optic nerves, prominent CSF around the optic nerve sheath, and partially empty cella. And then the MRV report read that there was narrowing of the distal transverse sinuses bilaterally, and you can see that narrowing on one side over here. We also got an LP, and the opening pressure of the LP was 50 millimeters of mercury, and this confirmed that papilledema was secondary to increased intracranial pressure. The CSF composition was normal, and the diagnosis of idiopathic intracranial hypertension was made, and we suspected that this was secondary to the doxycycline that the patient had taken for 1 month prior to presentation. So we instructed the patient to stop taking this medication. Her headaches improved significantly after the lumbar puncture, and she was started on acetazolamide 500 milligrams BID and quickly went up to 2,000 milligrams BID within 1 week. She was also started on furosemide 40 milligrams BID and had a boost dose of IV steroids. Her visual acuity and visual fields improved after treatment was initiated, and she was followed closely for the next several weeks and months. 6 months after her initial presentation, she was still on acetazolamide, 1,500 milligrams BID. And at this point, she denied any headaches, transient visual obscurations, tinnitus, and diplopia. Her vision had stabilized 20/40 and 20/30 in the left eye, and she still had a trace relative afferent pupillary defect in the right eye. Here's her fundus exam, and it's notable for optic disc pallor in the right eye. And here's her OCT. So this was on presentation, and this is about 6 months later. And you can see that there is RNFL thinning on the OCT, along with a disc pallor in the right eye. This is consistent with residual right optic nerve atrophy post-papilledema. Here's her Goldman visual field, and you can see that it definitely has improved since her initial presentation, but there's still inferior and nasal constriction here in the right eye to V4E, I4E, and I2E. So our patient remained stable from June 2016 to March 2018 without any headaches, diplopia, tinnitus, transient visual obscurations. Her visual acuity and visual fields remained stable, and there was no papilledema. And given that the patient had been off doxycycline for 2 years by this point, we made the decision with peds neurology to start to taper the patient off of acetazolamide. And over 2 months, we tapered her down from 1,500 milligrams BID to 500 milligrams BID to completely off acetazolamide. And she came back in May of 2018, so exactly 2 months after, with new headache and neck pain to the emergency room. She had an MRI and MRV, which was normal at this time, and we were consulted to see her in the emergency room, where we found that her vision and visual fields are stable, but she had a new Friesen grade 2 disc edema in the right eye and grade 1 disc edema in the left eye. And here you can see just with the OCT timeline. So this is from baseline, how she presented, and then she had resolved in this period of time, and then in May 2018, papilledema came back. So we restarted her on Diamox 500 milligrams BID, and we quickly increased it to 2,000 milligrams BID within a week. And unfortunately, no LP was done at this time. We just restarted her treatment. So the question is, why did this patient have a recurrence? We thought that her IIH was secondary to doxycycline, and she has been off of the doxycycline for 2 years. She's been stable on acetazolamide. Why did she have a recurrence? And that'll be our discussion for this case. Before we get to that, I'm just gonna go over some background on IIH. So IIH is diagnosed using the modified Dandy criteria. So that includes signs and symptoms of increased IIH, which our patient had, headaches, tinnitus, transient visual obscuration, absence of any localizing neurologic findings except cranial nerve 6 palsy, which our patient had, elevated ICP on lumbar puncture with unremarkable composition, and no other etiology of increased ICP on MRI or MRV. The incidence of IIH is between 1 and 3 per 100,000 persons, with a strong female predominance and a strong association with obesity and increased BMI. And previous studies have found that there's a dose-response effect with increasing levels of BMI associated with progressively greater risk of IIH. Studies have shown that as little as a weight gain of 5 to 15% is associated with increased risk of IIH, and weight gain as little as 6% is associated with recurrence in patients who have been stable. IIH is associated with several medications and exposures that increase its risk, and that includes antibiotics like doxycycline, also tetracycline, minocycline, sulfur drugs. Another notable exposure associated with IIH is vitamin A derivatives, retinoids, and also hormones, growth hormones, anabolic steroids. The management of IIH, there's really not clearly defined evidence-based guidelines for how to treat IIH. We usually treat with weight reduction and carbonic anhydrase inhibitors like acetazolamide. Diuretics can also be used. And there's, of course, surgical management, which we're not going to talk about in this presentation, but you can think about CSF shunting, optic nerve sheath fenestration, and venous sinus stenting. Vision loss occurs in 25% of cases of IIH, and 1 to 2% end up legally blind. Now, just to touch on fixed nerve palsy, so our patient did present with this. The most common causes of fixed nerve palsy are, of course, first ischemia, and trauma, and then third, elevated ICP. And you can see in the image here the course of the sixth nerve. So it makes two 90-degree turns, one as it exits the ventral surface of the pons, and then another one as it enters Zarello's canal. And it is here where it can become tethered against the bony canal and cause dysfunction with elevated ICP. To talk more about the pathophysiology of IIH, really the underlying pathogenesis is uncertain. Increased ICP is a uniform characteristic of IIH, but the mechanism by which it's increased is not clear. Perhaps there is a CSF overproduction. This can be seen in cases of choroid plexus papilloma or villus hyperplasia of the choroid plexus. But in those cases, you would expect to see hydrocephalus or increase in ventricular size, which is not seen in IIH. Another possibility is a dysregulation of fluid transport, which may be an important role in IIH, but there really hasn't been found to be dysfunction in the aquaporin channels that are involved in fluid transport. Another possibility is reduction of CSF absorption, which is probably the most likely mechanism. A reduction of CSF absorption by the arachnoid granulations may be attributed to either an increase in CSF outflow resistance or a reduced pressure gradient between the subarachnoid space and the superior sagittal sinus. And this is seen in cases of post-hemorrhagic hydrocephalus where there's blockage of the arachnoid granulations by blood cells and fibrosis, and also in cases of CSF hypercellularity, such as in malignant meningitis or where there's high CSF protein like Guillain-Barré syndrome. This can elevate intracranial pressure. And we know that obesity and female gender also play a role in IIH, and it's been shown that CSF leptin levels have been elevated in IIH, but it's really unclear how this plays a role in dysregulation of intracranial pressure. And now to talk about doxycycline and what's its relation to IIH. So this is a study that was published in 2019, and it was looking at the epidemiology of cyclin antibiotics, which doxycycline is one of them, and the development of pseudotumor cerebrae, or IIH. And it was a medical claims database review of 728,000 patients treated with cyclin antibiotics for acne, blepharitis, dry eye syndrome. And they found that 0.04% of these patients get a diagnosis of IIH. And the incidence of IIH among cyclin antibiotic users was double that for persons with no record of cyclin antibiotics use. And this difference was statistically significant. And then for each additional year of doxycycline use, it was associated with a 70% increased hazard of IIH relative to those with no exposure of cyclin antibiotics. But interestingly, there was no dose response effect. So our patient was on doxycycline for only 1 month before her symptoms started. And it's been shown that symptoms can start anywhere between 2 weeks to even 1 year of patients being on these antibiotics. Given that this patient had just been on this antibiotic, we speculated that this was the causative agent. But there are also other factors, like she did have obesity and she was a female patient. And we know that these also play a role and risk factor for IIH. But how does doxycycline actually cause an increase in intracranial pressure? Well, the proposed mechanism has to do with the drug's interference with the cyclic adenosine monophosphate, or CAMP, found in the arachnoid granulation. That there does not appear to be a gender predisposition or association with obesity in patients who have IIH secondary to doxycycline or other cyclin antibiotics. In a study by Shui et al. In 1998, of 12 patients who developed IIH from minocycline use, all patients remained in remission after acetazolamide treatment for an average of 23 weeks once they had completely gone off of the inciting medication. So once they were off of the cyclin antibiotics, they were treated, their pressure was treated, they did not have a remission. And many other studies suggest that stopping the drug and treating the increased intracranial pressure, even for a short time, should be sufficient. But our patient recurred, suggesting that either this was not secondary to the doxycycline, but she did have other risk factors like I discussed for IIH, or perhaps that there is some chronic changes from the drug's interference with the cyclic adenosine monophosphate that caused the arachnoid granulations to become fibrosed or scarred, that caused a chronic change and dysregulation in intracranial pressure. And now to just briefly talk about treatment for IIH, the big study that is always cited is the IIH treatment trial is a multi-center randomized double-masked placebo-controlled study of acetazolamide in 165 patients with IIH and mild vision loss. And their intervention was low sodium weight reduction diet and up to 4 grams per day of acetazolamide or placebo for 6 months. And they showed that the patients in the acetazolamide group had greater improvement in their Humphrey visual field, their weight, their papilledema, and vision-related quality of life. And they showed that the effect of acetazolamide on weight, which was almost double that of patients on just weight reduction diets, that effect of acetazolamide was actually independent from its effect on visual function. And these results were published in 2014. So coming back to our question, really we have 2 theories why this patient may have had a recurrence. The first one is maybe there are chronic changes in CSF fluid transport that reduce CSF absorption. And the second is maybe this is truly an idiopathic IIH and not secondary to the doxycycline. And perhaps she had weight gain after stopping the acetazolamide, and that caused the recurrence in her symptoms. So that's our first case, and I'm going to just very quickly go over our second case.
Catherine, just before you go on there, I just want to start a quick discussion here and ask a few questions. Can you go back? Well, my first question, because I think Dr. Elliman, you mentioned to me that your residents are listening and that I can ask them questions.
They are.
Okay, great. So what is, of all of the testing that we showed here, what is the most important one that helps us understand the visual prognosis in these patients? Maybe there's 2 that you might comment on, but what are the most important tests?
Who wants to
answer? If this patient is good, yeah.
You want someone here from the audience to answer, Dr. McIntosh?
I would love that. Otherwise, I'll have to ask Catherine to give me the answer.
I'll choose Julia Carvalho, please.
Good evening. Nice to see you again, guys. I had a great time in Chicago. So I think for the thinking about the visual prognosis of this patient, you showed her visual field, right? And
absolutely.
I think it's important, and maybe also the OCT could help. But also, as you showed, he had an improvement. So I think it's important as initial evaluation, but it can also change. But it's important, of course, to think about the prognosis.
Right. Catherine, can you go back to the visual field, the very first one that we showed on her, that Goldman?
Yeah. Let me see if I can.
And there's a couple of important findings here. Julia, can you, I think Catherine pointed them out, but some of these are worrisome and some of them are not as worrisome. So the worrisome one, Julia, is what do you see here?
We can see there's a contraction of the phoropters especially in the left eye.
Right. As I can see. Yeah, any visual field contraction becomes kind of worrisome that may not reverse. And in fact, we showed that later on, although the field improved, that right eye didn't go back to normal. But there's another one here that is less worrisome, and it's that blind spot enlargement. Look at the left eye with this large blind spot, and even on the right eye a little bit. That happens because the periretinal, the perioptic nerve retina elevates because of it. And you can actually refract that blind spot back to normal. So the blind spot enlargement is one of those things that, yep, we got to start treatment, but probably this patient will retain good vision. When you start to see that visual field contraction, that's the stuff that's really worrisome. And as we showed in subsequent visual fields, didn't necessarily return. I think the visual field is more important early than the OCT, because it shows these actual visual field changes that we know are predictive of visual loss. The OCT very early can be very unreliable, especially with very, very significant disc edema. These OCTs were not really designed to measure that degree of disc elevation. And so early on, the OCT is not as helpful. But later on, as we showed, it showed atrophy, and that's consistent with this right eye visual field loss. So early on, I feel the visual field is the most important test you can get. Later on, the OCT can give you functional information about how the nerve is doing. Catherine, can you bring us to the MRI pictures that you showed?
We also have here the preceptors of neuro-ophthalmology, Dr. Luciana Noia and Dr. Leticia.
Yeah, and I'm open to any other discussion or questions or about these. And here, a couple of important findings that were pointed out. And here you can actually see the disc edema. And in general, we say that the MRIs and the MRVs should all be normal. But some of the soft findings, do you have another resident who might be able to answer this question? What are some of the soft findings that you are allowed to have on imaging?
Let's see. Gustavo Samico, would you like to answer, Dr. McIntosh?
And you can see one of them here.
Yes, I think the patient has some hypersignal of the optic nerve in the left eye, close to the posterior pole, and she has also the signs that Catherine also showed us, such as the flattening of the posterior wall of both nodes.
Good. I'd be careful with the word signal. This is this is a T2, and I think that what you're seeing is the CSF around the nerve. I don't think the nerve itself has any signal in it. And that's one of the things you can see, right? The nerve is dilated. It's fluid around the nerve in the optic nerve sheath. And so you can see that with that CSF that bulges around. And then here you can see, as you correctly pointed out, the posterior sclera can flatten. And some of that has to do with the papilla here. That is, you can actually see the disc edema here. It's that prominent. You can also have flattening a partially empty cella. We need to look at a coronal or an sagittal in order to see that very well. So those are some of the soft findings you're allowed to have, but in general, the neuroimaging should be normal if we're trying to call this idiopathic. That's another point that I'd like to make. If we're thinking that this is secondary to the doxycycline, probably idiopathic intracranial hypertension is the wrong term. This is a secondary thing, although otherwise it has all the same features of IIH. But as Dr. Joltikov pointed out, after we stopped her acetazolamide, she should really have remained normal, and yet she recurred, suggesting that maybe this really was underlying IIH. Just before I take a couple questions, just another really interesting case, Dr. Joltikov, maybe in just 1 minute, I think it's 2 slides, just to present this other case of
great.
Secondary elevated intracranial pressure.
Pull that up, yeah. So our second case, very quickly, is a 28-year-old woman. She presented with a new blind spot for 2 weeks, and she has a past ocular history of Stargardt's disease that was diagnosed in 2010, confirmed by genetic testing. And she has a history of chronic migraines, but has felt worse over the last few months, and she feels like she is under 10 feet of water in her ears. She denied pulsatile tinnitus and diplopia, but she did have transient visual obscurations for the 1 month prior to presentation. Importantly, she was on a medication that was part of a randomized blind clinical trial for the treatment of Stargardt's disease, and otherwise past medical history was unremarkable. Her exam, she had a BMI of 25, vision was 2200 in both eyes, pressures were healthy, otherwise normal exam. Here is her fundus exam, and you can see that she also has 360 degrees of disc elevation, and you can see the visciform hypopigmented flex in the macula there. Here's her visual field, so you can see that she has this central scotoma, relatively normal blind spot. And here is her B scan, which shows no drusen, so it's true elevation of the nerve. With these testings, we can say that she has papilledema secondary to increased intracranial pressure here with the CSF opening pressure. So it actually turned out that this patient was part of the TEASE trial, which is a phase 2 tolerability and effects of ALK-001 on Stargardt disease. And ALK-001 is a chemically modified vitamin A formulation that is altered to prevent the formation of toxic vitamin A dimers in the eye. And it's hypothesized that this prevents lipofuscin accumulation. This was a multi-center randomized double mass trial where there were 3 arms, and 2 of the arms had vitamin A derivatives. And this was a 2-year study. So our patient was in the study, which we did not know which arm of the study she was in, but we presumed that she was in the vitamin A, one of the vitamin A arms. We started her on treatment with acetazolamide, instructed her to stop the study medication, and she came back 1 month later and her papilledema had improved, her visual field stabilized, and we were able to taper her off with the acetazolamide, and she was asymptomatic. We asked the clinical trial physician to break the mask to figure out what the patient was on, and unfortunately, they were unwilling to break mask, and the patient was actually re-challenged with the study drug 5 months after we had treated her because of promising interim results. And 3 months after the re-challenge, she actually presented with recurrence of headache, pulsatile tinnitus, transient visual obscurations, and new disc edema. And at this time, she wished to remain on the study drug. She declined repeat lumbar puncture, so we restarted treatment with acetazolamide, and her symptoms did improve, and thankfully the study did conclude 3 months later. And she did not have any recurrence of her symptoms once we stopped her acetazolamide. So to summarize the second case, it's a patient also with of intracranial hypertension that is secondary, we suspect, due to presumed vitamin A derivative, which is the studied drug. And she had a recurrence with re-challenging of the drug and is now in remission since the end of the study.
Great.
Thank you. And I know we're a little bit over, but I'm happy to take any questions or enter into any discussion at this time.
Okay. Professor Mauricio Maia, wanna?
Yes, actually, thanks for showing these cases for sharing these cases with us, Peter. And actually, I think it's important for our residents to know that the longest nerve inside the brain is the 6th one, and that's the reason sometimes it's affected. But I believe the most important thing here is in these patients that we have idiopathic hypertension, we should roll out the weight, obesity, and CO2 retention in patients that they have a sleep apnea or something like that. And for our residents, it's also important to know that cetosolic is important. The Diamox is an important medication. However, in chronic users, they may result in kidney stone as well as potassium problems. These points are very important. And overall, in cases that are with the recurrence of optic disc, sometimes actually the ventriculoperitoneal shunt is one option to save this vision. What do you think about that, Peter?
Yeah, you know, there was a study a few years ago called the SITE study. We were one of the investigators. I was one of the investigators for that, where the goal was to try to answer this question about what is the correct surgical treatment for these types of patients who fail medical management. Because at this time, we really don't know, should a patient be fenestrated or shunted or even stented? That's sort of become en vogue. But we don't have randomized data to answer that question. Unfortunately, the study a couple of years ago did not enroll well, and so the funding was pulled, and we at this time still don't have an answer. I generally, however, feel patients who are purely visual loss with papilledema, without headache, are mostly amenable to fenestrations, and that's what I've been doing over the last few years, and I've been very impressed with the fenestration results. Patients who also have headache, the fenestration is not quite as strong for reducing the pressure to control headache, and those are the ones that I typically send for shunting. We're still learning a lot about stenting. You know, and I've sent a few patients for stenting, but we're still at a place where I feel we don't clearly know what to do. And so some of that referral for surgery depends on what you have available. Do you have an orbital surgeon who can fenestrate? Great, let's do that. If you don't, then you're probably going to rely a little bit more on the neurosurgeons for shunting. But you're right, those are 3 surgical options that I've all used and have all worked, but we're not clear yet which patient is really the best for each of those.
Hi. I think Dr. Leticia Santana would like to give a word. We don't have 1 minute, Leticia, please.
Oh.
Luciana Noia also. Luciana, please. Both.
Oh.
Leticia,
then I go. Okay. Oh, great cases. Great cases. The first is about idiopathic, so a primary case, and it's so interesting the difference of the case. In the first one, we have the recurrence after all that of the medication. And the second one, we have the vitamin A. It's very interesting. It's very interesting as the cause of the IAA. So I don't know, Luciana, great cases.
Yeah, I would first thank you for showing us these cases. We had a case of isotretinoin use that we presented here in Greenhouse some years later. And it's very important, especially for teenagers and kids, to look after secondary causes, because it's not so useful to be idiopathic when you have a child. In this case, it was a teenager, so teenagers troublesome. They used to follow more the adults' patterns. And apparently this was the case because it doesn't seem to me to be related to the use of doxycycline. And it's important to reinforce, we use lots of doxycycline in Iih syndrome, and most people forget about this interaction. And I would like to ask a little about the follow-up of the kidney toxicity of acetazolamide. We used to use great doses of acetazolamide also. We usually don't arrive to 2,000 milligrams, but I think our obese are less obese than yours. But how do you follow these patients? Only which frequencies?
So you're right. I use a lot of acetazolamide, and often I'm at 4 grams daily. And I very quickly will titrate up there, especially for patients with bad papilledema. Based on the idiopathic intracranial hypertension treatment trial, that's how I know that dose of 4 grams. That's where that comes from. And even in that study, they found that patients just on the acetazolamide don't really need any monitoring of kidney function, so I actually don't do that. However, if I'm adding anything like furosemide, then I will start to monitor. Those are the ones that I'm a little more worried about, particularly for wasting potassium. So those patients, I will specifically check potassium and renal function if I'm combining acetazolamide with furosemide, for example. But just on acetazolamide, I'll warn them about some of the side effects that are actually quite rare. And if they happen, then we treat those, but those I don't specifically monitor for.
Excellent. Dr. Jotikov, Dr. McIntosh, excellent. We have some questions for you in the chat, if you could please answer. And I'm happy to announce Dr. Michael Massengill, and the preceptor will be Dr. Hyde.
Hi, my name is Michael Massengill. I'm one of the first-year residents here in Illinois. Dr. Hyde said he might be in surgery. Not sure if he's here.
Really? So who will be? So he, okay.
He is not here now, but I think we can handle even though.
Yeah.
Okay. Let's go for it.
Yeah, so I'm here a little bit. Dr. Hyde is tied up in the OR, and I think Dr. Chan is here as well, too. And hopefully he'll be able to join us in a moment, Dr. Hyde.
Sure. Okay, so Dr. Hyde's the director of the Inherited Retinal Disease Service at the Illinois Eye and Ear Infirmary. So I'm going to be presenting a case that was pretty unusual and kind of unique that came into his clinic. So this patient that came to his clinic is a 50-year-old male. He has hepatitis C and no personal or family history of ocular disease. And he came to Dr. Hyde's clinic for evaluation of bilateral blurry vision. This all started about 1 year ago. He developed blurry vision while being treated for hepatitis C with this new drug called Mavorite, and the course was for 6 weeks. The blurry vision occurred gradually over a few weeks during treatment, but after stopping the drug, his vision ended up stabilizing, but was still poor. He had already had extensive ophthalmologic evaluation, which we will discuss, and some of his other medical problems included chronic headache that was treated with venlafaxine and previous IV heroin use treated with methadone. His visual acuity was 2400 in his right eye and 2200 in his left eye, but his pupils and pressure were normal. And on the slit lamp exam, the anterior segment looks very unremarkable. On the dilated fundus exam, and here showing some fundus photographs, there was a question about possible very mild temporal pallor on both of his optic nerve heads, but the macula, vessels, and peripheral retina looked otherwise unremarkable. On fundus autofluorescence, there were no areas of hypo or hyper autofluorescence in either of his eyes. And when we look at the spectral domain optical coherence tomography of his macula in both eyes, we saw a normal foveal contour, a thick ONL, and no obvious areas of ellipsoid zone, interdigitation zone, or RPE damage. On Goldman visual field testing, however, he did have central scotomas in both of his eyes, and the right side was slightly larger than the left. So prior to coming to Dr. Hyde, the patient had been worked up for optic neuropathy due to this mild optic nerve pallor that was seen on the fundus photographs. And here it's showing his OCT RNL, which is generally normal. He had also had some normal brain imaging with MRI and had some laboratory work, which included inflammatory markers, nutrition, sarcoid, and syphilis, all returning negative. He had even gone to see a geneticist, and here's a picture of his family tree showing him as the only individual with vision loss. He even had genetic testing for inherited forms of optic neuropathy. So in general, this is a patient that had new central scotomas that began after starting a new medication for hepatitis C called Mavorite, and a normal appearing fundus. So the differential is very broad, and just in a general sense, may have included macula dysfunction, retinopathy, optic neuropathy, inattention, or non-organic vision loss. And we decided to go and perform electrophysiologic testing to help tease out the diagnosis. The first test we performed was a full field electroretinogram, an ERG. This is a test where flashes of light are shown to the entire retina, and and the electrical response of the retina is measured from electrodes on the eye. The response includes a negative deflection, which is called the A wave. This arises from photoreceptors, and a positive deflection called the B wave, which arises from bipolar cells in the inner retina. The two parameters that are important are the amplitude of these waves and the implicit time of these two waves, or just the timing of these two waves. This test can be formed in dim light conditions or scotopic conditions, which would test rod function, or with brighter flash or photopic conditions, which would be more towards the cone response. Here we're looking at the patient's ERG waveforms. On the top left, we have a control wave in black, and then of the patient's right and left eye in the red and the blue. What we see in the top left image for the black control wave is no A wave at this light intensity, which is normal, and a very high positive B wave. This gray box signifies the range of the amplitudes that would be expected, or the implicit times that would be expected for the waves. So when we look at these two ERG waveforms, which are done again with dim light, we see reduced amplitudes and prolonged implicit times, which is suggestive of rod dysfunction. Similar test was performed with brighter light flashes and also a flicker ERG. This showed a similar pattern of reduced and prolonged amplitude and implicit times for the A and B waves, showing cone dysfunction. So in general, these patterns suggested pan-retinal dysfunction in the rod and cone photoreceptor pathways. The second test we performed was multifocal ERG, and this test uses a light source with many small hexagonal areas of bright light that are shown randomly to the patient. And this tests the cone pathway in different areas of the retina, including the fovea. And this can be seen with the hexagons over the macula and the fovea in this image. The electrical waveform looks similar to the one we just saw, but the important wave here is called the P1 wave. And again, the amplitude and the timing of this wave is what's important. This wave is produced across a segment of retina, which is 20 degrees from the fovea in either direction. And here we're looking at the amplitude and the P1 timing of the waveform, where red is reduced or prolonged and green is elevated or short. But in this instance, we see that the P1 amplitude and the P1 timing are reduced in the macula and also involve the fovea. So from these two tests, from the full field ERG and the multifocal ERG, we're able to say that there's pan-retinal dysfunction with macula involvement. We next use pattern evoked ERG or pattern ERG and pattern evoked visual evoked potential or pattern VEP to investigate whether retinal ganglion cells or the optic nerve were also involved. These tests are based on contrasts that activates the retina or the occipital lobe. And it uses a checkerboard here, which reverses in pattern with time. And these checkerboards can be changed in size to elicit different responses. The general idea here is that multiple different electrophysiology tests, the PRG, the pattern VEP, and the ERG, can lead us to different diagnoses based on what results we find. We've already seen an abnormal multifocal ERG and full field ERG, so we know there's a maculopathy and a generalized retinal dysfunction already. This is the pattern.
Hey, Michael?
Yes.
Hey, Michael. Sorry. Hey, this is Rob Hyde, everyone. I'm sorry for signing in late. I just finished a case in the operating room. So, you know, I think that at this point, it might be good to kind of talk to our guests here and ask, you know, in what circumstances have you seen before a patient where, you know, the macula is basically benign. There are no fundus features, and there's an occult retinopathy that is potentially within the differential diagnosis. How would you approach that? Anyone want to, from Brazil, from their comment?
Yeah, you want our residents or our staff?
Sure, yeah.
Residents. So I call Mariana Davi for now.
Hello, good evening to everyone. Okay, so we have this patient with 50 years old. He has a blurry vision, bilateral. So, and he had some treatment for hepatitis C. So I end these exams when we see a Fundus exam that seems normal with a little of pale disc. So, and also with these multifunctional Erg and also other electrophysiology exams, where we can see a reduction of the cones and the rods response. So in this way, I would think a little bit of maculopathy with dystrophy of rods and cones. Something that's very rare, but came with in my mind. It's the Azor, because we don't have a lot of findings in the fundoscopy, and we have these dysfunctions of outer retina. So I think it's a very challenging case, but these are my guess in this moment.
Yeah, let's see. Dr. Mauricio Maia is on. Can you?
Yes. First, Hyde, thanks a lot to share this case with us. Very well presented by Michael. Actually, I think in general cases, to think about Azor is very important. However, in patients with hepatitis C, a very normal, very common drug that we use is interferon, right? And in this case, we may have sometimes cotton wool spots, hemorrhage, and vascular changes. In this case that you presented here, I think it's very important to have the electrophysiological study. However, the dystrophic diseases may be ruled out as you guys did. So these are my comments about the hepatitis C and also the retinal implications of the treatment in this disease.
Let me see, Dr. Caio Rigatieri.
It's a very nice case. It's a challenging case, but when you have some patients with hepatitis C, usually you see like vasculitis, you don't see this kind of a lesion on common rods. So my guess is it's related with drug toxicity.
Great. So those are all excellent potential diagnoses that we considered as well. And certainly with respect to Azor and hepatitis C, as well as interferon-related retinopathy, we would see some other stigmata on the exam, which we did not really. And so we were going to further investigations really with these pattern ERG and VEP to really nail down where within the retina, optic nerve, or distal to that the pathology lies. So I'll let Michael, you can resume where we were. So we've summarized so far, we have a patient with panretinal degeneration as revealed by full field ERG with macular involvement, and there could be potentially other areas of toxicity, including the retina, the optic nerve, or distal to that. So continue, Mike.
Thanks, Dr. Hyde, and those were all very excellent points. So what we're talking about is the pattern ERG. And again, this is a response of the retina to a checkerboard. And what we're looking at is the waveform that's produced during this test. There's two important waveforms, the P50 wave which tells us about macular or cone function, and then the N95 wave, which tells us something about the retinal ganglion cell function. And there's two major patterns that we can see. One is a reduced P50 wave, which would be suggestive of macular dysfunction, and the other being a normal P50 wave with a reduced N95 wave, which would be more consistent with the optic nerve pathology. So what we're looking at here is the control wave in black again, and then our patient's waveform in red. And what we see is a very attenuated P50. And this again is consistent with the macular dysfunction that we've already seen, and really does, and at this point, it looks more like the optic nerve is not affected. The pattern VEP tells us very similar information, and we also performed this one. This also has a waveform composed of 3 different waves, and in this case, the P100 is where all the information is held. The amplitude and the latency are what tells us for the P100 what disease process we could be seeing. So for example, in the case of prolonged P100 latency, macular dysfunction can be seen. And when we look at our patient's waveform, again with the control here in black and our patient in red, we see a latency which is consistent with macular dysfunction. These waves aren't perfectly clean, but we interpreted this as latency consistent with macular dysfunction. So at this point, we're fairly confident in saying that the optic nerve was not involved. So to summarize what we have so far, we have an acute onset of vision loss in a middle-aged male. He has a normal fundus. He just started a new drug. He's got central scotomas and now ERG defects showing both pan-retinal dysfunction and a maculopathy. And we already had a couple good suggestions from the audience, so I'll just go straight forward through this. One would be a drug-induced maculopathy, central retinopathy due to his new drug. Another good option would be occult macular dystrophy, which we will discuss. A second good option is autoimmune retinopathy, or AIR, which we'll also discuss. Inherited retinal degeneration was also considered. He did, however, undergo genetic testing later on, and that returned negative, so we will not discuss that today. And I heard Azor in the audience, and this also is a good option, especially in the early stages when OCT findings aren't very evident. But at this point, the patient had already had the disease for a year, so we thought that this was less likely. So occult macular dystrophy, or OMD, is a rare, usually autosomal dominant retinal degeneration with a mean age of onset of symptoms between 25 and 30. We considered OMD because it can cause visual acuity loss in scotomas, but with the fundus appearing basically normal, as seen in this example on the right. The most common mutation is the RP1L1 gene. However, 50% of patients actually don't have an identifiable mutation. And of note, the RP1L1 was included in our genetic panel, and that came back negative. Since OMD is a macular disease, the characteristic ERG findings are a normal full field ERG with a decreased multifocal ERG showing macular dysfunction. And as the disease progresses, there are signs that show up on OCT, which includes disruption of the ellipsoid zone in the interdigitation zone and some retinal thinning in the central retina. So we ended up thinking that OMD was less likely because we saw pan-retinal dysfunction on the full field ERG, and at least as of this point, the OCT was normal, although at later appointments, other signs may develop. Autoimmune retinopathy, or AIR, was another disease that we kept in mind. This is a disease where anti-retinal antibodies cause rapid progression of rod, bipolar cell, and/or cone dysfunction. And AIR comes in 3 types, that being cancer-associated, melanoma-associated, and then a non-paraneoplastic form that's associated with autoimmune disease. There's multiple different types of antibodies that can be produced during this disease, and these all yield different phenotypes. So there's a variable phenotype that could occur with AIR, but they all lead to some form of rod, bipolar cell, or cone dysfunction. And three major aspects of this disease are symptoms that are consistent with cone and rod dysfunction. For example, changes in color vision when cones are affected, or night blindness when rods are affected. An unremarkable exam, at least early in the disease, especially without any inflammation. And then ERG, or visual field defects that will progress through the disease. We thought that Erg was also a less likely option because he did not have any signs of autoimmune disease or cancer. And after a year of follow-up in the clinic, he didn't have any progression of his disease. Which brings us to another option, which is drug-induced maculopathy and retinopathy. And this table shows that there's multiple different ways for drugs to affect the retina and the macula. But one interesting one is photoreceptor dysfunction. And two examples of this are digoxin, which can cause decreased visual acuity, color vision, photopsias, and scotomas through inhibition of the sodium-potassium pump. And this will lead to defects in the ERG waveforms. A second example is isotretinoin. This is a vitamin A derivative, and it can cause night blindness through inhibition of recycling of vitamin A in the RPE, and it can also cause scotopic ERG issues. A newer example is pentosan polysulfate, which can cause a maculopathy associated with nyctalopia, prolonged dark adaptation in blurry vision in some cases. On the Fundus exam, there are sometimes yellow lesions with scattered hyperpigmented lesions at the level of the RPE. And there's also autofluorescence changes. These are occurring near the fovea or in the fovea. It's interesting that this drug was approved in the United States in 1996 for interstitial cystitis, but it was not till 2018 until the maculopathy was described. So that brings us full circle back to the drug that we talked about at the beginning. That's Mavorite. This is a FDA-approved drug for chronic hepatitis C. It's composed of two different protease inhibitors that inhibit the replication of the virus. And this drug is dosed for a period of 8 to 12 weeks and has an excellent response to eradicating the virus. This drug is also very popular because it can get any of the genotypes of HCV. It's okay for those patients with renal impairment, and even patients as young as 12 can use this, and it's continuing to be studied for additional indications. Some of the adverse events that are known are headache, fatigue, nausea, and pruritus, but it's interesting to consider from our case whether visual disturbances would be a potential adverse event. So as far as take-home points from our presentation, we think that Mavorite may have caused a drug-induced maculopathy and retinopathy, but of course this is a single case, and it's very possible that this patient might develop OCT changes later on in his time in our clinic. But as this graph shows over to the left with time on the x-axis in years, and then the number of new drugs on the y-axis, the number of new drugs that are introduced in practice are continuing to increase with time. And as of 2014, we're up to over 1,400. So as ophthalmologists, we're probably going to have a point in our career where we have a patient with new ocular symptoms and comes in with a new drug. And it will be our job to decide whether this is an association or is this just circumstantial. And the last point from this presentation being that combining multiple ERG, multiple electrophysiology tests, those being the full field ERG, multifocal ERG, pattern ERG, and pattern VEP, this can be very helpful in diagnosing unexplained visual acuity loss. And this is shown here on this flow chart to the left. Thank you for your attention.
Dr. Hyde. Thank you, Michael. Dr. Hyde, how close are you following this patient, and how are you following him?
Yeah, so this patient originally had presented about a year before to UIC, in the neuro-ophthalmology clinic, and then presented, to me about 10 months ago. And I've seen him about 3 times since then. He's been very stable on exam. And the thing that was really interesting about his clinical course is that he really emphasized a temporal correlation between his symptom onset and the use of this medication. So while we didn't have any baseline testing on him prior to starting the medication, which would be much more strongly supporting the association with this and the maculopathy, the vision essentially stabilized, although poor, once he stopped taking the medication. So he was on it for about 3 weeks, and then his vision has been at 2200 for well over about 18 months now.
Hi, may I ask you one question, my friend? Once again, congratulations for the case. Actually, for our residents, it's very important in hepatitis C to be sure about the autoimmune retinopathy and also the drug-induced retinopathy. In this case, did you guys discuss it with our colleagues about changing the medication to actually interferon?
Yeah, so he had basically discontinued the medication about at least 1 year prior to presentation. So he had decided after 3 weeks that, being on it, that he would not continue on it. And then he did not pursue any alternative treatment for hepatitis C, for chronic hepatitis C. And so he has been managed by an outside gastroenterologist with whom I've been trying to get in better communication, but she's affiliated with a different institution, and I have not found that he has a desire to pursue any other antiviral therapy at this time.
Okay, wonderful. Congratulations.
So I'm curious. I would love to hear from you. Being in Sao Paulo, have you had any experiences with patients who may have had a unusual toxicity or reaction to one of these newer medications? Because as Michael pointed out on his last slide, we are constantly being flooded with new and new medications. Many of these are oncologics or antiviral medications. And oftentimes, I've never heard of some of these medications before the patients actually present to my clinic. What's your experience with that?
Yes. Actually, I'm going to search for this kind of patients now. But actually, our experience is with interferon, when we see sometimes the cotton wound spots and also vascular changes. But actually, this is a occult case of probable toxicity. So I think the beauty of this case is this occult manifestation of the disease, and I think you guys should publish this case because it's very interesting, and we are going to see if we observe cases like that, which is very very interesting.
Well, stay tuned, Michael. Michael is on the publication, and he will be hopefully getting this submitted fairly soon.
Yes.
Kaya, what would you like to comment?
Yes, very nice case. In our university, we have a huge clinic. As Mauricio said, and we are going to search this kind of patient. We see some patients with interferon toxicity. And my question is, since you don't have any retina architecture change, do you think this patient will have a back vision, or you think it's going to be vision loss is going to be different?
Yeah, I think that there was some encouragement he had once he stopped the medication. He thought subjectively that his vision got slightly better, but then it regressed. And it has basically been in that level 2200 for, over 18 months. So I would say that it would be, I think that time span makes me less optimistic that vision would return. However, certainly with patients, by analogy with autoimmune retinopathy, which we don't think this is, you sometimes do see that patients will improve their vision once they're on immunosuppressive. So in the absence of any treatment, I don't have any reasons to suspect that his vision would return, unfortunately.
So our chairman wants to give some words, like Dr. Maynard is on.
Hi, thanks, Norma. Just to say thank you, the guys from UIC. Very good presentations, very good cases, and outstanding discussions. Thank you very much for joining us again, and have a good night.
Thank you so much.
And I have Dr. Nilva Moraes, my co-coordinator of the grand rounds here.
Hi, thank you very much, everyone. Great cases, great discussion, great night, Norminha, great night. Thank you very much to all of us.
Thank you all. Dr. Hyde, Michael, thank you very much. Mauricio, Caio, Nilva. And let's say bye, good night.
See you, my friend.
Thank you, good night.